Hi, hello, welcome back. 19-year-old teen presented with recurrent TAS. What is your diagnosis? This is diffusion weighted imaging, FLAIR image, and this is the angiogram. Yes, this is an interesting case of Moya disease. Moya is a chronic cerebrovascular disorder characterized by progressive narrowing of intracranial portions of distal internal carotid artery, initial proximal components of middle cerebral artery, anterior cerebral artery. The progressive stenosis causes decreased cerebral blood flow to brain parenchyma, causing ischemic and a compensatory vascular response. The cerebral vasculature attempts to compensate by developing collateral circulation and enlargement of pre-existing microperforated arteries such as lenticulostriate and thalamoperforating artery. The formation of the blood vessels gives typical angiographic appearance of puff of smoke appearance. So this puff of smoke appearance is roughly translated as Moya disease. So this is one interesting thing you need to identify is the name given to the angiographic appearance of the collateral vessels, which gives a typical puff of smoke appearance. So 90% of the patients present with ischemic stroke, 7.5% present with TAs as in our case. Very rarely they can also present with hemorrhagic stroke. There is bimodal distribution below 5 years and after 4 decades of life. Females are more commonly affected in Moya rather than males. It can also be associated with NF1. We had 1 or 2 cases of Moya associated with NF1 with sickle cell and Down syndrome. So here coming to the MR imaging, the diffusion weighted finding, diffusion was equivocal in our case. In FLAIR, you can see some hypointense linear veins here, very subtle findings. Sulcal spaces are obliterated. So these are most probably collateral vessels. On contrast, they lighten up and give typical IV sign. In our case, we have not performed contrast, so we can't demonstrate IV sign in this case. So here, and also in these are the 2 images of internet where the dilated perforated arteries, perforating arteries giving a typical termite night shape of appearance, and also multiple collateral vessels, which actually on angiogram become a puff of smoke in bilateral capsular ganglion regions. So here, angiogram showing severe narrowing of bilateral MCA and right ICA. Here, the blue arrow showing the collateral vessels in the lenticulostriate region. The posterior circulation is well preserved. There are focal stenosis of anterior circulation. So anterior circulation is not completely spared. However, the posterior circulation is normal in our case. Coming to classification where it fits and perfusion. Here, there were large perfusion defects. Actually, compared to there is definite FLAIR and diffusion mismatch in our case. FLAIR and diffusion appeared absolutely normal. However, there were larger perfusion defects in our case here. So stage 1 is narrowing of only the terminal internal carotid. Stage 2 is there will be Moya early formation of collateral vessels with the dilatation of internal main cerebral arteries. Stage 3, which is the most common form where there will be intensification of the vessels and major trunks. They become severely stenotic and they start occluding. So our case fits into the stage 3 Moya. Stage 4, 5, 6 are relatively rarer. In last stage where there will be abnormal external carotid anastomosis from the to the internal carotid, and posterior circulation gets more affected in stage 4. So as I said, our case fits into stage 3B where there was partial preservation of both anterior and middle cerebral arteries. Thank you very much. Hope this video on Moya syndrome or disease was useful for you. It is important to have high degree suspicion to diagnose collateral vessels and if possible perform a distal subtraction angiography and contrast study of MRI to diagnose a case of Moya disease. A vessel wall imaging has a definite role where you can see the intima-middle thickening and we can definitely differentiate the the thickening from the atherosclerotic disease pattern.